Well, good evening, everyone. Welcome to Dental CE Academy. I'm Dr. Rowling. I'm the Chief Education Officer here, and we have a great live webinar this evening, Pathogenic Pathways, Oral Systemic Links. Pam Cushenan will be joining us here. And before we get there, let's review the housekeeping. I want to give a great shout out here to ioTech International that has supported many of our classes, and they are supporting our course this evening. The agenda for this evening, 5 to 6, will be the continuing education portion, and followed by a 30-minute product demonstration by ioTech International discussing their molecular iodine oral care products. Now, this is not required for CE credit. We are to let you know that. So you are able to log off, or if you stay on, either way, you will get the quiz, and there will be a promotional discount for our attendees. CE credit instructions are below, and if you could all tap on that red banner at the top of the screen to download the handout and CE credit instructions. Many of you may have received it by email just about 30 minutes ago as a reminder. And with that, I am going to go ahead and introduce Pam. And Pam, I'm ahead of schedule here, so this is great. Pam Cushenan, thank you for being here this evening. And Pam's a passionate health professional dedicated to providing cutting-edge educational sessions, as well as connecting care providers with methods to improve the welfare of older adults and other vulnerable populations. A national speaker, an education specialist, a researcher, an advocate for the advancement of access to care options. There is her contact information. We'll have it on the last slide. Following her presentation, about the last 5 or 10 minutes, we're going to be taking questions. So be sure to post your questions. Pam, welcome, and I'll be here in the background. Thank you for being here.
Thank you all so much for joining us today. This is really exciting because we as oral health professionals recognize that oral pathogens can wreak destruction on our whole body health as well. And we're going to go into some details about that. So the objectives today for you all by the conclusion of this course is to describe the presentation of oral health versus oral disease, be able to state that inflammatory impact of periodontal pathogens on the whole body, discuss the evidence-based oral systemic causal links versus the increased risk of negative health consequences, and analyze options to reduce the pathogenic oral systemic impact. All of this is important for us as we move forward. So there is a quote here by the FDI World Dental General Assembly, and they represent dentistry across the whole world. The quote is, "Oral health is multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex." That is so important for the welfare of everyone. As we know, gingival tissue should be pink and stippled and knife-edged and have a scalloped appearance as much as possible as we age. Teeth are intact with no active decay, and we don't note lesions within the oral cavity when we're doing our examinations. So that's our oral health. When we consider the oral cavity, we know there's a lot of bacteria in there, but we have over 700 species of bacteria inhabiting the oral cavity, which is just fine when we keep it in some type of balance or symbiosis. We want to have, not that we get to choose, but we want a higher gram-positive population than a negative gram-negative population. And I listed some of these for you, the difference between the gram-positive and gram-negative cocci and rods. So those are listed there for you. They're in your handout. And so I want you to review those just to be familiar with them. Now, these are the big bad dogs. Okay, these are periodontopathogen bacteria. You're going to see these names come up throughout this presentation when we're talking about the systemic impact of these bacteria. So I have in bold the first one, which is Porphyromonas gingivalis, PG. Each one has their own initials. Prevotella intermedia, PI, Treponema denticola, TD, Tannerella forsynthesis, TF, Campylobacter rectus, CR, Aggregatic bacter, Actinomyceta comitans, AA, and Fusobacterium nucleatum, FM. Again, you will see these again and again as we speak to the different impact on various areas of the body. Now, these bacteria that I just listed, when they are out of balance, they release inflammatory mediators and toxins that can go into our bloodstream and interact to create a systemic inflammation. This is a big deal. So we know that when a patient has periodontal disease, that they're going to have a much higher risk of these negative impacts. So we've already talked about how many bacterial species are existing. When these bacteria get out of balance, when they're no longer in symbiosis, it goes into a state of community disturbance or dysbiosis. So this is when there's more gram-negative bacteria in the population. These keystone pathogens that we listed, that you can refer back to, are the ones that can really interact with different parts of the body to cause these variations that create either a chronic medical condition or an acute medical condition or exacerbate those. We know that perio disease is a persistent infection. It's not something that, like gingivitis, that we can treat and it's like, oh, you're perfectly healthy again. No, it's a management disease. And so because of that, and because so often it's not very well managed, we see these systemic interactions, and it actually interacts and creates things such as Alzheimer's disease, CVD or cardiovascular disease, diabetes mellitus, rheumatoid arthritis as well. So again, when they go from symbiosis, when there's a reasonably balanced amount of bacteria and type of bacteria in the mouth, into dysbiosis, that's when we have problems. So we all know about the bloodborne movement of bacteria through the body. We've heard about that for years with CVD and heart attack, stroke, etc. So we're going to look at 3 routes today, not just one. So one, we have the bacteria entering the bloodstream and moving throughout the body. We have an oropharyngeal pathway, which is where we often see aspiration pneumonia resulting. We also have this one, before I really started researching this some years ago, it didn't occur to me. We have orodigestive or intestinal dysbiosis and gut-mediated systemic inflammation that has been shown to contribute to metabolic syndrome. Who knew, right? So with these systemic pathways, we know that where there's increased gingival inflammation, because there's systemic inflammation, increased gingival inflammation, usually due to a localized factor or a health condition that's reducing that immune system, it can go into periodontal disease from gingivitis, where it was a wonderful reversible condition that we could manage, to something that we cannot restore to full health. So into perio disease. When that happens, we already talked about the bad bacteria, the periodontopathogen bacteria that release these pro-inflammatory mediators into the system, which increases that inflammatory state of the system. Then metabolic syndrome components are affected. More pro-inflammatory mediators are released, and then the body's in systemic inflammation. It's a really good visual and shows a vicious cycle of how this can affect the body. So systemic inflammations, bacteremias, also, we know, can cause or exacerbate chronic medical conditions. So we talked about metabolic syndrome. Well, that includes obesity, high cholesterol, heart disease, etc., type 2 diabetes, non-alcoholic fatty liver disease. I mean, really, that is affected by these type of systemic inflammations. Also, our cholesterol levels, right, is shown to elevate or increase the LDL and triglycerides, which we want to keep low, and reduce the levels of the good stuff, which is the HDL or high density lipoproteins. Also, we've already talked about Alzheimer's disease. There's inflammatory disease, rheumatoid arthritis, colorectal cancer, and we've known for years about adverse pregnancy outcomes. And we'll be discussing all of this in future slides. Now, it's not just adults that deal with periodontal disease. Normally, when we see children or adolescents, it's a form of gingivitis that we're dealing with almost all the time. But sometimes we'll have a periodontitis situation, the juvenile periodontitis type. However, when there are certain conditions going on with children and adolescents, these disorders can lead to periodontal disease. Some are some serious infections without bone loss and some with bone loss. There are two hematological disorders. One's acquired neutropenia and one is leukemia. Then there is a plethora of genetic disorders. And I can read all of these to you. Familial and cyclic neutropenia, Down syndrome, leukocyte adhesion deficiency syndrome, Papillon-Lefèvre syndrome, Chidiac-Higashi syndrome, histiocytosis syndromes, glycogen storage disease, infantile genetic granulocytosis, Cohen syndrome, Ehlers-Danlos syndrome, and hypophosphatasia. So these are different conditions that can result in some serious issues for them when we see them as dental patients. What has to happen is no matter how wonderful we are as oral health professionals, we have to have interprofessional collaboration with their care providers. We are not a standalone silo. We are a healthcare team, right? So we want to be able to coordinate care and really address these periodontal pathogens that are exacerbating these situations. Our services, we are there. We are the experts. Routine plaque control, mechanical debridement, scaling and root planing, soft tissue curettage, hopefully with a laser, right? Depending on your state. Use of selected antimicrobial agents. So we have ways to address this and help these individuals to better manage their situation. However, if there's an aggressive periodontitis issue, it doesn't respond very well normally when they have these type of conditions, and it usually results in antibiotic need as well as multiple extractions. I did include some charts for you that will show you which of these conditions involve diseased bone or bone loss and which one have no alveolar bone loss, but there are things for us to be aware of. So you can just review that at your leisure. They're very good charts, though, and they give you lots of information. Now we're going to move on to the majority of those we see with periodontitis and with the different medical conditions that this interacts with. So we're looking at 6 in 10 adults that have chronic disease and 4 in 10 adults that have 2 or more chronic diseases. And these are listed here for you. Hypertension, high cholesterol, arthritis, diabetes, heart disease, chronic kidney disease, heart failure, depression, Alzheimer's disease and dementia, and COPD. For those of you who are listening, unless you're like 29 or less, you probably have one of these already bringing up little bits of issues for you that continue as we age. Moving on to the leading causes of death and disability according to the CDC. Here we go again. Heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease, diabetes, and chronic kidney disease. So you're seeing overlap. You're seeing a few in one area that wasn't in the previous one. But all of these things are showing links to periodontic pathogens. So Nazar, who is one of the researchers that I've studied, showed a great chart listing all of these things I just spoke to, including preterm births. And we're going to go further into how that happens. Here's another great chart for you showing all the different parts of the body that these bacteria can travel to through those 3 routes that we discussed. It shows not only the areas that the bacteria can impact, but also the modes of transmission as well. Now, we're going to individualize the different conditions, starting with CVD, cardiovascular disease. When you see 17.5 million deaths worldwide, you know that's a big issue. Well, atherosclerosis is what causes that inflammation of the vascular system. And what they're finding, what the research is finding, is that these periopathogens have been found in these AS plaque. And the ones that we listed already are the ones that they're finding in the atherosclerotic plaque. This is a big issue. Incident of atherosclerosis is 1.27 times more common in patients with periodontitis. So again, we're having what seems to be a very direct link, right, between periopathogens and atherosclerosis. Atherosclerosis causes myocardial infarction, stroke, and limb ischemia, involving the medium and large arteries. And what happens is these bacteria enter, cause that endothelial barrier disruption that pops out the immune system response, of course. Then the monocyte adhesion and aggregation takes place. Foam cells are promoted. Foam cells are lipid-filled cells, which destabilize that area further. You'll see, or not you, but it is seen that necrosis and calcification takes place, and these areas can rupture and detach to form a clot or a thrombus. And again, they're finding the very bacteria that we have listed for you in these plaques. Moving on to diabetes. It's a huge issue all over the world, but in our country as well. And so many of the patients may not even be diagnosed. There's probably 5 million in Georgia, where I live, the state of good Southern cooking, right? But anyway, type 2 diabetes, there's 90 to 95% of diabetic patients, that's what they have, type 2 versus type 1. That's when the pancreas stops producing enough insulin and may stop completely. And in that case, then insulin injections are needed. We know the symptoms are polydipsia, polyuria, nocturia, fatigue, increased infection, leg cramps, paresthesia of fingers and toes, impotence, and blurred vision. We have the opportunity as healthcare providers to use a glucometer in our office for those who have diabetes, especially if they're not managing the knowledge base with their A1C. They should know their A1C. So we need to be checking on those with those type of patients at each visit. But when a patient, if you use a glucometer, if they show a fasting glucose of 100 to 125 milligrams per deciliter, that's considered prediabetes. That's an A1C of 5.7 to 6.4%. If someone is diabetic, then their fasting blood sugar will be 126 milligrams per deciliter and higher. Their A1C will be 6.5% and higher. Now, when I have a patient in my chair and they are diabetic, they're on meds or insulin or whatever it is, I want not me, it's recommended that their A1C be at 7% or lower. Some people are able to manage their diabetes through exercise and diet, and some, of course, require oral meds and or insulin, depending on their situation. Complications, if someone is uncontrolled, and there's a narrow window of control for diabetics. If someone is not maintaining their control, then we often see increase in decay because of glucose pooling in the saliva. And also a really important fact with this interactional situation between periodontal pathogens and the system, clients that have diabetes are 3 times more likely to develop perio disease. They have if they're uncontrolled, an unstable immune system. Also, there's poor collagen formation and increased tooth loss in patients that are not controlled. So we want to definitely encourage them to do so. When we're looking at the oropharyngeal route of transmission of periodontal bacteria into the body, then one of the key things I mentioned earlier is aspiration pneumonia. And that is when the alveoli become inflamed and they can fill with pus or fluid. This causes 15,000 deaths each year, approximately, in adults 60 years and older. That's a lot of people dying because of this bacteria, in this case, entering the lung and setting up infection. Obviously, poor oral hygiene is a huge part of this. Dysphagia, which is a swallowing issue, and dystusia, which is a coughing issue. That's where they can't cough completely to move the bad bacteria out. Different classifications for acquired pneumonia, aspiration pneumonia, are community-acquired, hospital-acquired, ventilator-associated, and nursing home acquired. So those are the 4 classifications, basically just where were they when they developed their pneumonia. The causes is inhalation of bacteria, fungi, or a virus. If it's a viral pneumonia caused by a virus, that is not as big a deal because that is a self-resolving issue. However, bacterial-based pneumonia is a more severe issue and creates much of the hospitalization and potential deaths for our older adults. Symptoms: difficult or shallow breathing, fever, weight loss, frequent throat clearing, and a productive cough with foul-smelling and or tasting sputum. Who's at most risk? Those who are over 65 or under 2 years, because that's another issue. Have a heart or lung condition, a poor immune system, and or have neurological conditions that will cause the swallowing disorder, like Parkinson's disease, stroke, and dementia. When a person inhales these bacteria through choking in their sleep, they might have sleep apnea that's not being treated, etc., whatever it is. If their lungs are healthy, if the host is relatively healthy and this bad bacteria enters there, or when it does, they can cough it right out and it's not going to be an issue. However, if it's not expelled, that's when it can set up that infection and create the aspiration pneumonia. Also, COPD individuals have an increased rate of periodontal disease as well. Pregnancy outcomes. Interestingly, the placental environment is very much like the oral environment. And so when we see these intrauterine infections, they're looking at the PG, periodentopathogenic bacteria, and the FN that we discussed earlier. That's what they're finding in those areas with these infections. Where'd they come from? Interprofessional reinforcement. So we need to be not just keeping that patient's incredible education and everything within our operatory or within the practice setting. We also need to be involving their OBGYN, their whatever. We need to make sure that all hands are up to date and know what's going on, because it's causing issues with them and can cause some serious negative pregnancy outcomes for the patient. Those include maternal infection, preterm birth, low birth weight, which can cause things like hyperactivity, developmental disability situations with babies under 4 pounds, preeclampsia for the mother. And we know again that these periodontopathogen bacteria are involved with doing these adverse pregnancy outcomes. Now, chronic kidney disease. Yes, not only is periodontal disease involved in the situation with chronic kidney disease, but these are considered to be bidirectional infections or issues, okay, conditions. So if you'll look at your slide, patients with chronic kidney disease have a 30 to 60% incidence of perio disease. 30 to 60% because their kidneys are sick. Patients with both chronic kidney disease and perio disease have a 35% risk of mortality compared to those without perio disease. I think we have a lot that we can do to help these people, right? Cancers, again, who knew? There's an increased cancer risk related to perio disease. Tongue cancer, they're showing evidence that tongue cancer risk increases 5.23 times with each millimeter loss of alveolar bone. That's huge. Perio also is involved with oral, esophageal, gastric, and pancreatic cancers. And that F nucleatum, or FN, is also very strongly associated with colorectal cancers. That would get my attention if I'm in the dental chair with perio disease. All right. Our next condition is rheumatoid arthritis, a very painful, debilitating condition. Here's another bidirectional situation. When someone has perio disease, there's increased rheumatoid arthritic symptoms or activity that takes place in the body. There are also patients with RA have more bone loss when they have perio disease combined with that, more bone loss and subsequent tooth loss as well. And you'll see the ones that we've already discussed, PG and AA, as the primary pathogens noted in this issue. Also, guess what? When we provide periodontal therapy, this can help reduce those symptoms. And I have my best friend in the world has RA, and it has kept her in bed for years, and it's taken her time to get this under control. And part of that, I believe, is the fact that she's on a good dental services regimen now with her dental hygienist. And that's a big deal. I mean, changes her life. So as we know, patients with RA have a poor immune system. They have the bacteria that we just talked about that create these things called citrullinated peptides that bind with proteins, and it increases the tissue destruction related to perio disease. The gut dysbiosis also, so we're going to go to that third leg of the routes of transmission. Gut dysbiosis also creates these anti-citrullinated protein antibodies, ACPA, that are important to be assessed. So this is, I don't know about you, but I'm not assessing anybody's gut dysbiosis. Oral, yes, gut, no. But this is, again, where we need interprofessional collaboration so that these type of things can be assessed to determine if there's an issue so that that can be treated and therefore lessen the RA symptoms. That's our goal. Now, moving on to something no one ever wants to deal with personally, and that's Alzheimer's disease. You're looking at over 47 million people affected worldwide now. This is a growing issue because our aging population is growing exponentially, right? So what they're finding is the perio disease is moving through the bloodstream and crossing the blood-brain barrier. I'm just going to knock it out a little for you there. There's a 7-fold higher population of oral bacteria in the brain tissue of the deceased patients, because when a patient has Alzheimer's disease, they can't 100% declare that until there's an autopsy after death. But they're finding this huge population of perio disease bacteria in the brain. Okay. So that's an issue. Now, with that, there's a 6-fold increase in cognitive decline associated with perio disease bacteria. Again, this gives me great motivation as a human being to avoid having that issue in my life. So we get back to which ones are found most frequently in the brain. There's spirochetes or treponema, FN, PI, H. pylori, and B. burgdorferi. Also, P. gingivalis, PG, that's the worst, as they say, the key pathogen of chronic periodontitis, very strongly found in brains of patients with Alzheimer's disease. So again, that's huge evidence of a pathogen traveling to other parts of the body. Severe osteopenia, especially in women that are postmenopausal, there will be a potential lessening of bone density due to the lack of estrogen. And if they develop osteopenia or osteoporosis, when there's a presence of periodontal disease, then there's going to be a huge increase in the rate of bone loss, of tooth loss, of degeneration of that system. So again, we really need to be managing these patients closely and working with their healthcare provider to interact and keep everybody on the same page. So now we get to the teeth of the matter. We're looking at prevention and management. And this is where we live, all of us, the dental team itself, whether you're a dental hygienist or a dentist, even dental assistants have some input here as well when working as hygiene assistants, etc. We do oral care assessment and education. We recommend dental hygiene or dental products. We do provide the therapeutic dental hygiene services, and we come up with recare strategies that work best for that patient in an individualized manner. Starting it out, we need a thorough medical dental history. There are so many different methods, even today in the technology age, of how these are filled out. I still see paper forms that are just uploaded into the computer. Very important to review that carefully. Ask follow-up questions. Do a little digging, because patients will often go, oh, that doesn't matter. It has nothing to do with my teeth or my gums or whatever. So update at each appointment. Ask questions, not just, have you had any changes in your medical history? And do you have any sensitivity to hot, cold, or pressure in your mouth? I mean, that's like traditional, boom, boom, done, move on. But there are patients that were prescribed meds that they're not taking. That can be really dangerous. They're supposed to be on high blood pressure or diabetic meds or whatever, and they're not taking them because can't afford them, don't like the side effects, etc. So ask these questions for the patients. Every year, get a new medical dental history. Just have them fill out another one. It's not that big a deal. Have them come in 10 minutes early if they have to. That way they're waiting for you when you're ready for them. The next thing, make sure you're doing intraoral exams. This is something, when we look at research, it's like 36% of dental offices in this country provide routine intraoral exams for patients. There's a lot to be said for those who do this, because we find items to observe, we find items to refer, and of course, when we find these things, we discuss it with the patient, and I show them in the mirror for sure, because I want them to see what we're looking at, because the 2-week rule still is an important thing. If this item that wasn't there last time I saw you, or I'm seeing you this time for the first time, and there's this item in your mouth, or this discoloration, or this whatever it is, I want the patient to know. And if it's still there in 2 weeks, we want to follow up on it. Okay. That's a really important deal because when people ignore these things, oral cancers have a terrible prognosis. Terrible. So, and I have stories, but I don't have time for them right now. We'll talk another time about patients that did follow through and still lost most of their palate. All right. We're doing a periodontal assessment. We have to have radiographs, whether they're taken in another office at a short time prior to that or the ones we're taking. We want good radiographs. We want bone level. We want root tips. We want all of it. Because when we take that baseline full perio chart to get that clinical attachment level, we want to be able to actually determine what stage, what grade is that in, what level of perio, depending on where you are in the latest, greatest determination of disease. There's all kinds of different methods of collection, whether it's you've cross-trained office staff that are writing things down for you or inputting it in your computer or wherever you happen to be. But get that data. We need a comprehensive charting their first visit. We need to do a full charting at least every year. And for me, even when I have patients just come in, they're my good recares, they're minimal issues. I always go through with the probe and screen for any inflammation, for any PD or pocket depth that may be questionable, okay, that wasn't there before. So anyway, this is an important part that we need to manage each time. Here's a big deal. Again, we're on a time limit. Some offices are crazy and you're assistant hygiene, so we'll give you 30 minutes. Girl, please. But anyway, it's important that we assess that patient. I use disclosing solution, and I use disclosing solution because that is a visual that the patient can identify with. So first of all, this helps to determine what that patient, I'm asking what they're doing. How are you taking care of your mouth every day? I'm not beating them down, right? I want them to tell me what they're doing. Then we're going to disclose and see how well that works for them, right? So it's going to determine if, one, they're effective or not, or if it's a recare appointment, are they being compliant with things that we've worked with them on or not, or do they need further modifications? Also, we are being able to give them direct reflection on how they're doing and what they can do to be more effective to help protect themselves from all of the stuff we're talking about, and we can track their progress at each appointment. In order to work on self-care, I need to know what kind of brush they're using. Is it manual or is it electric? Or what type is it? Because there's some alternate items out there as well nowadays. So what type's used? How are they using it? Normally, people using an electric brush are using it just like a manual brush and losing the effectiveness. And that's what we're here to determine, to give them an opportunity to improve in a way that makes sense. I talk about getting more bang for your buck or working smarter, not harder, and that appeals to them. We always need to find the patients with them. What's in it for me, right? What's in it for me? Well, less discomfort, less expense, less whole body health impact. It's pretty cool. All right. We also want to talk about brush type and replacement intervals because some patients need adjustments on that as well. And they may have toothbrushes that are all spread out everywhere. And we want them to know how to take care of that and what to do if they get really sick with the flu or COVID or whatever. How are they going to handle that toothbrush? We need to be sharing that with them. Interproximal devices. Are they using anything? And if they are, what is it? And how effectively have they been using it? Remember, we've disclosed, right? Floss is not for everyone. Interproximal proxa brushes are not for everyone. Water picks are not for everyone. However, there's usually something for our patients if we work with them on what is considered manageable to them. I want it to be understood to do something. I don't care if it's water floss. I don't care. Just do something to help because the toothbrush is obviously inadequate to do it by itself. How many patients have exemplary hygiene? Not a whole lot. Some do. I give them attaboy stickers. Then there are oral rinses, irrigations, etc. Now, these have been very important in my practice over the 36 years I've been practicing and still do as a dental hygienist. Based on what I find in their assessments, what's their periodontal status, what's their inflammatory status, of course, what is their method of self-care, are they effective, etc. Well, I'm going to recommend, do they have a chronic medical condition? That's a huge one. If they have a chronic medical condition, I'm having them pre-rinse before they clean their mouth morning and night. Pre-rinse, lower that bacterial load before they do anything, right? So that they protect themselves from systemic inflammation. So we want to determine that. What is the frequency? Are you using it before each time you clean your mouth, or are you using it before and after, etc.? What is the delivery method? Is it through a cup with a 30-second swish? Is it through in the water flosser reservoir? Is it a gel delivery system? I mean, there's a number of ways to get this type of oral rinse or irrigation into the patient's mouth. Or is it being delivered through my ultrasonic through that reservoir? Anyway, my preferred properties that I have found that have worked the best for my patients over the years, non-alcohol is my preference. Again, I want to protect that tissue. Have a high bactericidal impact. That's what the heck I'm trying to do. We all are trying to do is lower that bacterial load. Is it substantive? Or is it a one and done? See ya. Everything's back to bacteria party system in your mouth. Or is it something that's going to last for hours or even days? Then non-staining. I have not met a patient yet that has said, give me a mouth rinse that's going to turn my teeth brown or blue or whatever color. It needs to be non-staining, and it needs to have an acceptable taste. We want our patients to want to keep their mouth clean and want to use an oral rinse that will actually help them to manage their oral health, right? So that's a very important part of these oral rinses, or when we use them as irrigations as well. Also, I want it to be something. Here's another, I didn't even put this in here. I want it to be an item, a rinse, a method of delivery that they can use as long as they need to and are not restricted to only 10 days or 14 days because of very negative impact on the mouth, even though it's helping bacteria, but it makes the mouth look terrible and feel terrible. So those are some of the important properties for me for the oral rinses I use. Now, obviously, for our therapeutic treatment and management, when we are addressing our patients based on their assessments and diagnosing their perio, we need to treat it. We need to treat it in the best method possible. Again, some states are able to use lasers in addition to their scaling and root planing. There's all kinds of great stuff out there today. When we are practicing to the national standard, it's even better for our patients. When we are treating patients effectively, look at this. It can reduce systemic inflammatory markers, and it may positively influence that metabolic status of the patient, reduce glucose and A1C in our diabetic patients, improving kidney function. Because remember, one of the complications of diabetes is nephropathy or kidney issues, kidney conditions. Also, in hyperlipidemic or high cholesterol patients, reducing the LDL and triglycerides, increasing the good stuff, the HDL. Wow. I think I want to keep doing this as long as I can. So recare management, each time we see a patient, it's not a fluff and buff. It's a re-eval that perio status. If they're not responding, and we've already exhausted our arrestins and all of that, refer them to a periodontist, please. You know, we can't hold patients hostage with 7mm pockets and think we're doing something. We want to have a healthcare team. We also, of course, want to make sure that we're overseeing what they're letting us know about their health history, or in our intercollaborative work with other professionals, we want to keep up to date on that as well. So that is our treatment phase. Here is my conclusion. We are not just dentists and dental hygienists and dental assistants. Dentists and dental hygienists, the licensed providers that are treating these patients, we provide critical care dentistry, because it's not just about another pretty smile. It's not just about nice breath. It's about the entire welfare of a person. It is helping to reduce negative consequences, unnecessary negative consequences. So we want to base our dental hygiene treatment plan, or dental treatment plan, on assessment findings, educate these patients. We're not trying to use a total fear factor, but a knowledge base helps them make a well-informed decision on what health risks are caused and exacerbated by oral pathogens. We want to lower that disease burden of oral systemic impact through our treatment and interventions that we do. I mean, this is what we are experts at. Also, we want to strategize individualized self-care recommendations, re-care intervals, interprofessional consultations, and referrals, whether it's a 2-month re-care, 3, 4, 5, 6 year. Everybody's different. But these are the things that we want to make sure are part of our practice philosophy and actual implementation on a daily basis, because we are that awesome in the world of patient care. Just saying. With that, I'm at the end of my educational session, and I hope this was all that and more for you. Now, I'll be happy to take your questions.
Okay, so we have a few questions here. We're going to go to full screen. I do want to remind everyone that jumped on a little late, you do have a handout, and it's the exact replica of the slide presentation. So please tap on that red banner at the top of the screen. You'll be able to access that handout. Mm-hmm. Okay, let's go up here to the top, Pam. There are some questions here that just came in. There were questions about using Cavitron. We'll get to that in just a minute, but let's start here. There are a lot of good bacteria in the mouth as well. Are oral rinses worth killing the good bacteria as well? I suppose this is very case-based.
I would say very case-based. I believe in recommending rinses based on that patient need. I don't recommend rinse to every single patient I have. You know, every like I say, it's an individualized situation. So when we look at rinses, we should be aware of what pathogens they are effective against. And when a patient is in dysbiosis, it's that important for us to kill those bad bacteria, creating the systemic inflammation, and get them through that period and into a management situation. So it's worth it.
Here's another question, and these are all great questions. How does measuring the bacteria in the saliva test help after we give them 10 days of recommended RX, whatever? What do we do next other than SRPs, laser, iorinse, etc., especially when they don't show a lot of tartar and their hygiene is good but just bleeding?
When we have exhausted our skills, our treatment regimen, this is when interprofessional collaboration comes in. If they are still having issues and we have done everything, you know, full Monty with our patients, we need to be directly interacting with their cardiologist or their primary care physician or whatever, because there's more going on than oral issues, in my opinion.
I would agree. From Jody here. Oh, excuse me, go up one. What mouthwash brand do you most often recommend to your patients with moderate to severe gingivitis and perio?
Am I allowed to?
Well, you can go ahead, and we're going to be talking about this after the presentation, Amanda, so I hope you'll stay on, but go ahead.
Okay, the one that I most recommend, I have two that are good for perio patients. But when I have someone that's in trouble and that cannot seem to manage themselves, etc., I do go with iorinse. Why? You want to know why? I do that because I can put them on that for long term without them staining and coming back with a ton of calculus on their teeth, right? And it doesn't make their food taste weird, etc. I get a higher compliance with that, and I get a better outcome with that patient as well.
And we'll be talking about that during the 30 minutes after this presentation. Okay, let's say we have a question here about disclosing solution on anterior restorations. What is your feeling about that?
My feeling about that is I use a cotton tip applicator because I know that secret. And we don't want to paint up something like that. So all I do is I paint the teeth and I avoid those teeth. I rinse the mouth. I can have the patient remain open. I rinse the mouth. Hello, the plaque's going to stick on the teeth, the natural surfaces, etc. And that patient is going to get that excellent education based on that without me compromising the beautiful prosthetic work that they have.
Better not send my composites looking like that. That's for sure.
No.
That was my nickname, Composite Queen. Okay. Could do miracles with composite. Is there a benefit to use the phase contrast microscope of the bacterial plaque at chair side?
I have not had experience with that, so I cannot answer that question for you.
Okay, and we do have a class, William, on our site on phase contrast microscopes that was presented by Tasha Kozlowski. So if you're not familiar with it, if you go to On Demand, you'll learn more. What are your thoughts on, I'm sorry?
You said I will also take that class.
What are your thoughts on oral probiotics to improve balance of flora?
My jury's still out on oral probiotics. I have utilized them as well. I just don't have enough, I guess, research-based information yet to feel comfortable with recommending that to my patients at this time.
There are some studies out there that you can, in some cases, improve breath. Depends on the patient again. You know, not everybody's oral microbiota is the same. So it's the same thing with the gut. Let's see here. What terminology is best for plate replacing WNL when tissue appears normal, otherwise known as we never looked? Go ahead.
Oh, do I love you? Whoever said that is too awesome.
That was me.
No, that was you.
That was whenever I saw WNL, it was we never looked.
Never looked.
Right.
I love that. But, you know, we can say no concerns. I mean, we can say that instead. No apparent concerns, because we don't know that 100%.
When tissue appears normal. I think most folks, don't you agree, recognize WNL across the board, except the medical world sometimes, right?
Yes, because that's what we, you know, I'm a retired assistant professor of Georgia State University dental hygiene program, and you betcha WNL is what everyone's taught as an acronym to get us, you know, consistent communication.
Right. So when my students mark WNL, that's when I take a closer look. Let's see here. Is it a good idea to start on metronidazole and chlorhexidine for perio and then use iorinse?
I'm sorry. I don't. When I look at what I've read about the two, I just go straight to iorinse is where I go. The metronidazole, I don't see a conflict with that and the iorinse at all. But I do tend to have, like I say, I don't want my patients coming back stained and with more calculus on their teeth. And of course, I have to tell them, don't do this if you're going to be eating or drinking within 30 minutes of your rinsing. So that makes it a little difficult. And also, I want a longer substantivity. So that's why I go with the iorinse as well. That's
good. And I agree with you. And I think also, Pam, that the use of antibiotics in some of these situations, we really want to reduce that because of antibiotic resistance. And you happen to be hearing from someone that had a C. difficile infection from clindamycin after a perio procedure. So when we're discussing antibiotics, we really need to make sure that we're going to get an outcome from it, right? And C. difficile is not the outcome you're looking for here. Also, chlorhexidine is just not a good antiviral either. It's just, let's see, we've got some more questions and we have some time. So thank you all for asking these questions. There are questions here about iorinse. If you can stay on a few minutes, you'll learn everything you need to know about iorinse. And there'll be some product demonstration as well as promotions. For patients on chemo, can they use iorinse and for how long? And I think that would be a question that they could send in to Dr. Moskowitz, to iorinse. So we'll put that contact information for you in the chat area.
Excellent.
I would imagine, and also they're having a product that is going to be released for oral mucositis, which is really important. So stay on for the 30 minutes and then definitely contact Dr. Moskowitz through the website and we'll have the contact information here for you. Okay. Not sure if this was asked exactly, but have you heard of oral DNA and what are your thoughts on it? And go ahead, and I have my thoughts as well.
Again, you know, I really only like to speak to things that I'm familiar with working with, and that is not mine. So I'm going to pass this to you.
Okay. So I am very familiar with oral DNA. So when I was the chief for the Office of Oral Health for Maricopa County's Health Department here, I ended up with $60,000 in grant money that I did not spend, which is bad because then you lose it, right? And I always wanted to perform salivary testing on my patients that were expecting because we were out in the field, we couldn't probe, and many of the hygienists were just counting on, you know, visuals. But because Maricopa County has such a high morbidity and mortality rate, I wanted to know, one of the highest in the country actually, I wanted to know, do these patients actually have infection? And these were young women. So we did use oral DNA. It's one of the largest studies in the US. It's still going on today, even after I've left, which I'm very proud of. And so they're looking at the data because I would have to review these reports coming in. And I think it's good to know what pathogens they have on board so that you can be very focused in your treatment, right? Because when we perio probe, we're looking at architecture and what we've lost. We're not, you know, if you get a strep throat and you go to the primary care doctor, they're going to just swab you and take a culture probably. They're not going to poke you with something and say, well, it looks like an infection, right? So yeah, so it was very beneficial. And then we talked about chemo, NPN, no pathology noted, okay. Often the results lead to taking antibiotic for treatment in addition to PMT after SRP. I think the antibiotics are changing and hopefully they will change. You don't have to answer this. It's very hard to read this, Beth. It looks like if you're on your thumbs, there's some words that didn't come through. So if you could clarify that, we'd be happy to address that question. Okay. Sorry, it's so long and I just wanted to make sure we got it. Yes, micro can indicate type of bacteria as well as presence of amoeba, indicating patient is dying.
Whoa. What?
I'm not sure. Beth, you might want to clarify that for all of us. What about hydrogen peroxide rinse diluted with water?
It just doesn't have the effectiveness to really address the periodontal issues that's going on. I get that 50-50 rinse, you know, if I'm having a little issue, I might want to gargle with it or something like that. But I'll tell you my personal story at the top of the product presentation information, why hydrogen peroxide just wouldn't cut it for me. And if it's not going to cut it for me, why would I say to my patient, oh yeah, go do that?
And even though it was recommended during the peak of COVID, right, by the ADA. The problem also is that it's not effective. You'd have to rinse with it for a long time, and it's still not effective. If you take the course by Dr. Moskowitz on our website, Oral Rinses, What's Safe, What's Effective, you're going to learn why hydrogen peroxide was banned by Health Canada, for instance, because it's not effective at all. Okay, questions about iorinse again, and I would encourage you all to stay on a few minutes and learn, because it is effective for aphthous ulcers. Talk to cardiologists. Not sure Dr. Sugg will still working, but work closely with cardiologists and internist weight loss doctors. What's the correct way to use an electric toothbrush?
The correct way to use an electric toothbrush is to not agitate it. When we use an electric, the bristle head is doing the agitation for us. So we teach the patient to place it on the tooth, let's say the buccal surface, and I have it just where you can feel it touching the gum line, because I want them to obviously not miss the gum line. And they slowly bring it forward. Electric brushes, real electric brushes, are going to have timers in them also. So they go all the way pretty much to the canine, then they turn their brush head, this is for the buccals, and slowly go all the way to, let's say, number 15. And then they're going to pause there, come all the way back to this canine, flip, and start at the other canine as they go back to that tooth. Same thing on the mandibular. Then on the linguals, they're going to use the same horizontal handle hold to, again, the canine. Then they go into a vertical position so that the bristle heads actually manage to cover that surface of the tooth. After they get to the other canine, they go back into horizontal on that lingual, again, on the tooth at the gum line as well. All the way back, pause, come all the way back, vertical, across, vertical. And I say use the head of the brush just like brushing your hair from the back of the tongue to the tip. Voila.
You can tell she's a pro.
Oh, and chewing surfaces just slowly back and forth. You just have to let the bristles agitate long enough to detach the plaque. That's the whole time. And utilize the full 2 minutes. If they don't have a timer in their brush because they're not cool, then they need to have Alexa, set my timer for 2 minutes or whatever.
So we are at the end of our question period here. And Pam, you did an excellent job. I want to invite everybody to stay on to learn more about iorinse and other ioTech products here. Pam is going to sort of bridge her portion with how she became familiar with ioTech's products and how she incorporates that in her care plan for her patients. And I'm going to go ahead and bring up the presentation. And I know we have Angelique is joining us here. Here she is. She miraculously appeared. Okay, everyone. So I am really honored to introduce you to Angelique Adderley, who is, Angelique, what exactly is your role at ioTech? I know it's the national something of something.
With ioTech, I've been with this company since the beginning. Been through the research and development stage. I work closely with Dr. Moskowitz, basically doing all the day-to-day operations, all the researching, new product development. I kind of have my hands in all of the different elements of ioTech as a whole. And as a result, I've been able to learn all about the technology, learn about all the benefits, and really trust and believe in everything that Dr. Moskowitz is trying to teach, and just know that it's actually works. And that's why I'm such a, I've been with them for almost 8 years now, and I am blown away by the technology, by the results that we've had, and the growth of the company. So my role here is basically helping the company to grow and, learning as we are doing that.
Well, I've had the pleasure of working with Angelique for almost 5 years. So I can tell you, if you have questions about the products, definitely reach out to her. And we're going to put a banner at the top of the screen to reach out to ioTech. And for those of you that would like to stay on, and we hope you will, please have your questions ready for Angelique. And for those of you that did not get the CE credit instructions, because I see questions about that, tap on that red banner at the top of the screen real quick and you'll have your CE instructions. All right, Angelique, we're going to go ahead and have Pam talk about her story for the first couple of minutes here, and then we'll go ahead and turn it over to you. Thank you both.
Thank you. And this is so cool what happened with me. I went back to work. Of course, COVID hit, right, in March 2020. I went back to work in July in this beautiful office in Buckhead. And lo and behold, the doctor was using iorinse. And of course, we are looking like space people, right? And he said, I want this used as my pre-rinse because it's so effective against virus. It was one of the main components that he was concerned with, of course. And so I was like, I'm all good about that to reduce aerosols further, even with our high-speed techniques that we were using during Cavitron use. And so that's where I got my initial introduction. And of course, I am a natural researcher. I do research with a company, as a matter of fact, at this time. And so I began researching the iorinse, and so I started using it on some of my patients that I was getting that were just, especially with the COVID situation, and people were, over the next 2 years, they just weren't coming in, for like a year at a time, and they'd come in a whole wreck. And the iorinse was making such a difference. And like I said, they could use it long term. They could get all the way through their 4 to 6 week reeval after SRP, and it would be like, oh, thank God, because it just kind of helps take out the slack for those who are not very good with their manual dexterity for their self-care. So anyway, so that's what happened there. And so I've been finding more and more uses for it over time. And again, it's very based on my patient assessments. It's not for everybody. It's for those I believe will best benefit from it. Now, on a personal note, this is huge for me, is I had an implant placed maybe a year ago now. I'd gone on vacation, and I will confess, I didn't floss for 2 days. 2 days. And I got back in there, and I was like bleeding like a stuffed pig around my implant. And that's scary, people, to have a $5,000 investment and something that makes me look like I'm not from my hometown of 800 people. I didn't want it to fail. So I had nothing. I didn't have the iorinse with me, but buddy, as soon as I got home, because it was red blood, bleeding terribly, even with all my extra ministrations, the special head of my electric brush, everything. So I get back home and started using my iorinse. 3 days. Periimplantitis cleared up in my mouth. And when I went back in for my regular checkup and everything, because I wasn't worried anymore, I wasn't bleeding to death, the dentist said I looked great, the tissue was good, my hygienist was happy, life is good. So I got to use it on myself, someone who does have good manual dexterity. It just I happen to have the kind of immune system that says, don't slack off of your daily care, girlfriend. So anyway, iorinse has worked great for me, and I've found that it works well for my patients. And so that's why I recommend it to them to this day. Ta-da! Angelique.
Thank you. Thank you so much for your experience with iorinse. I think that's where they got me since the beginning of all of this, is just the fact that it works. And that's my absolute favorite part of all of this, the technology and all the different products that we have here. I can actually speak on something that really works. And I love to hear about everybody else's experiences as well. Thank you. Okay, thank you all for staying on tonight for the product portion of this webinar. I hope to be able to answer some of the questions that you did ask about products and present to you something that can be used to mitigate a lot of the symptoms and help with a lot of the issues that Pam did discuss in this webinar. So on the screen, we do have our current line of ioTech products. These are all molecular iodine-based products. So they all contain the molecular iodine technology. Our first product on the top left is our iorinse Ultra. Now, iorinse Ultra is ioTech's first OTC product. This is, we can make our anti-plaque, anti-gingivitis claims for this product. It is available in a soft mint flavor in 1 liter size or 16-ounce sizes. The 1 liter bottles come in 12 1-liter bottles per case. The 16-ounce bottles come 24 bottles per case. Next up, we have our OG products. This is our original ready-to-use product. One of the first products that we did develop. It's ioRinse RTU, available in green apple and soft mint flavors. Both of these rinses are available in 1 liter sizes as well as 16-ounce sizes. Again, the 1 liter bottles come 12 bottles per case, and the 16-ounce bottles come 24 per case. Next, we have our ioRinse concentrate. Now, unlike the ioRinse Ultra and the ready-to-use, which do not need to be diluted for use, these can be used as is, straight out of the bottle for daily rinsing and for pre-procedural rinsing. Our ioRinse concentrated irrigant is used for water irrigation devices at home. You can use it in your water pits for daily use, or you can use it in water irrigating devices in office. ioRinse concentrated irrigant is available in green apple flavor in 1 liter size bottles, 12 1-liter bottles per case. ioGel is our tray gel. This is a thicker formulation of the molecular iodine. ioGel is used with a periodontal tray at home. So patients would take some of the gel, put it into their tray, place the tray into their mouth for about 5 minutes. Then they would spit out the excess, rinse out their mouth. So ioGel is available in 12-ounce bottles. There are 12 bottles per case. At the bottom left, we have ioCleanse, which is our hand cleanser. Now, ioCleanse is non-alcohol, non-staining. So this is something that is not going to stain your skin. It's not going to dry out your skin. Does give you all the benefits of molecular iodine. So all the great things that it does inside your mouth, you can have this on your hands as well. So ioCleanse is available in a 1 liter bottle, 12 bottles per case, and it also includes a spray head to apply to that bottle to make it easier to just spray your hands and have all those benefits as well. We have 2 nasal products available. So just as we want to protect our oral health, we want to protect our nasal as well. So first up is our ioMist nasal spray. ioMist is a saline-based nasal spray, so it's very gentle on your nasal passages. It's available in a 1-ounce mister bottle. So this is something that would be sprayed inside your nostrils. It is a 1-ounce bottle, 24 bottles per case. However, with ioMist, this is a personal product. So this is something that you would provide to your patients, or the patients would purchase and they would use individually. It's not such an economic solution for in-office use. However, we do have ioShield, which is our nasal barrier cream. The nasal cream is available in a 2-ounce jar, which breaks down to maybe a few cents per patient, because it's used with a disposable applicator. You swab a little bit inside each nostril, pinch the nostril, and it provides a physical as well as the molecular iodine barrier for any viruses that would be expelled during procedures. Both of these are nasal based products, those directed for nasal use. ioShield is much more recommended for in-office use because of the economic factor. Both are absolute great products, and we have a great response. Patients absolutely love them. The ioShield is available in 9 2-ounce jars per case. Now, just as we are protecting our own oral health, we also want to protect our pets' oral health. So for that reason, we do have our first pet product, which is ioVet Oral. This is a pet water additive. So instead of trying to hold your pet down and brush their teeth daily, you take ioVet Oral, dispense a small amount into their drinking water 1 time per day. The pet drinks the water, and they are provided with benefits for their oral health as well. So the molecular iodine would be something that can help with freshening their breath and also helping with plaque buildup on their teeth. ioVet oral is available in a 4-ounce bottle. It also includes a graduated dispensing syringe for easy measuring and dispensing. And there are 18 units per case for ioVet oral. Now, we do have a promotion going on for this webinar. We have a promo code. If you see it at the top of the screen, it's buy 2, get 1 free. So with this promo code, you go onto our website, you order 2 cases of any product, choose a 3rd case of another product, and the 3rd case is going to be free. So you use that code buy 2, get 1. And that's going to allow you to get a case of the products. And you can mix and match the cases. They don't all have to be the same case, but that is a buy 2, get 1 free for this webinar. Now, we are going to provide you with a contact form and a link to that contact form, which also going to give you that promo code. If you fill that out, you will be able to receive a sample of our IO rinse and also some information packets of some literature and other things that can be sent over to you. So I'm going to encourage you to head to the website, take advantage of that promotion, and also contact us for more information, and we'll love to schedule you with to get more information about using ioRinse products. We do have virtual office learns. So a virtual office learn is we'll schedule a time where you can set up your office with our team so that we can provide information about the products for in-office use, about using our products for at-home patient use, and also about clinical tips for best treatment outcomes. Some people may be familiar with ioTech products, and also there are a lot of people who may not be, but have heard about the benefits. So this is a great time to ask questions, get more product information, and find out how it's best to use this, this line of products for a profit center within your practice, or as well as becoming a brand ambassador where you can earn a commission, but ioTech would fulfill your orders. So all that is provided through this virtual session. You simply scan that QR code or send us an email, contact@iotechinternational.com, and we'll be happy to schedule a time for you to set up this virtual office learn, provide samples to your team, and as well as literature and other information. In 2018, Clinicians Report did an evaluation of our first 2 rinses. So the first 2 was our ready-to-use oral rinse and our concentrated irrigant. So in this study, there were 250 patients. 125 of those patients used the concentrated irrigant in their water pick at home. 125 of those patients used the ready-to-use oral rinse. The patients were taken from 50 offices, 5 patients per office. And this just gives you a quick evaluation of the overall rating that they got back from those patients who used the rinses. As a result of that evaluation, Clinicians Report did list us in their buying guide for best products of 2019. And then again, as a best products of 2022, came as a result of our the study that was done in Clinicians Report in their April 2021 newsletter. We just recently found out that last year we were in our listed as best product of 2023, and again as a best product of 2024. So we are continuing to keep that momentum going. We appreciate the support, and we appreciate all the feedback that we have been getting, which is why we can definitely, brag and say we are the best product of in Clinicians Report's buying guide. This is a list of just a very few of many key opinion leaders that do recommend ioTech products. All of these articles are available through ioTech International. We will be happy to provide you a digital copy of any of these articles, and a lot of them are also included in that literature packet that I mentioned. If you fill out that form, we can have those sent over to you as well. If you do have any questions about anybody's recommendations or any articles that were written, please feel free to contact us. We would love to speak with you. We would love to answer any questions that you have, and we encourage these questions. So we will provide our contact information. You can always reach out to us through our website as well, and we'll be happy to provide anything in a physical format or a digital format if that's more convenient for you. Now, I did mention using iRinse as a profit center in your practice. Now, we do know that some practices stock product and others don't. So because of that, we do have that choice. And I mentioned our brand ambassador program, which you can get more information about that as well. However, if you are an office that stocks product, this is just a quick illustration of profits that could be realized through the sale of ioTech products. Now, ioRinse is a product that can be used daily, ongoing for patient at-home use. So therefore, this is something that you can continually recommend to them, and it's something that's going to benefit them and also benefit you as a practice. So this is just a quick breakdown if that is something that your practice does as stocking product. We provide wholesale pricing through our website for the sale of ioRinse. So you can order in wholesale quantities and also order in bulk quantities. So anything above 10 cases is considered bulk, and you would get an additional 15% off those orders. So we do encourage offices to sell products to their patients, and we do support that by providing the discounted pricing. This is just a quick economic comparison of oral rinses. We do know there's a lot of options out there. ioRinse is a great option, but it's also a very new option that a lot of people may not be aware of. This is not a prescription rinse. It can be obtained through our website and also through many dental distributors. So this is just an economic comparison at standardized to 1 liter bottles. To show that even with all the benefits of ioRinse, it's still one of the most economic options out there for you. Okay, and finally, we do have our product availability. So I did give you a brief mention of how many bottles are available per case. All of the products are manufactured in the US. They are all available in stock, and we do ship either same day or next day, depending on the time. Just go to our website, take advantage of that coupon, that promo code, buy 2, get 1. That's available, buy 2 cases, get 1 free. If you do have questions, you would like samples of the products, you would like literature, please contact us at contact@iotechinternational.com, or simply scan that QR code, fill out the form, and we will be happy to reach out to you, speak with you, answer any questions that you have. We'll send samples for you, and as well as literature packets. We are available Monday through Friday, 9 a.m. to 5 p.m. Eastern Standard Time. And we'll be happy to answer any questions that you may have and get you started on the use of ioRinse in your offices.
Thank you, Angelique. And I wanted to remind everyone, if they tap on the banner at the top of the screen, it will take them to information about getting the samples, the information, the product, the promo code. So tap on the banner. If it's information you want to take back to your practice tomorrow, you can go ahead and bookmark that URL on your device as well. We have some questions for you. And let's see, how does your product compare to sodium hypochlorite penetrative rinses? I'm going to say, Katie, if you take Dr. Moskowitz's course, and I have the link for you there. In fact, it's right above your question. It's available on demand, and Dr. Moskowitz will break down just about every antimicrobial rinse known to man, and you'll get that information in that course. And it's 1.5 free CE credits. It's also offered live every month. The other thing is, if you've ever used sodium hypochlorite various rinses, they're not very tasty either. So, and if you have any sort of inflammation, it doesn't feel very good either. So it's not a great first impression for your patients. It tastes pretty bad. All right. What are the effects on the good bacteria and nitric oxide? Katie, again, I would reach out to Dr. Moskowitz through the website, and he's going to be able to answer that question for you and also take the course if you have it. Question here, Angelique, when are these products going to be available in Canada?
So I know a lot of people have been asking us this question. We used to be in Canada as with a distributor. Currently, we are working on getting our products back into Canada. So I would give it a few months, and we'll definitely give you updates in our webinars and also on our website, because I know everybody is anxious for us to get back in Canada for sale, and so are we. So that is definitely something that is in process at the moment. So we will keep you updated on as soon as that's available. It will be posted on our website for sure.
How about Mexico?
Mexico, I'm not sure of the regulations for Mexico, but that's something I can look into. And if you would, you could give us a call at our office even tomorrow. We'll definitely be able to answer that for you. We'll look into that for you.
Any other questions for Angelique or Pam here? Pam is staying on.
Thank you, Pam.
I couldn't
Yes.
resist.
Pam, any comments you would like to make?
I just want to say to Angelique, thank you so much, because even though I've watched Dr. Moskowitz's course twice now over the years, over the last, since 2020, this was really good information about the different variety as well as the prices. And I mean, this was really well done. Thank you very much.
Thank you very much. And I look forward to bringing out a few more products in the very, very near future.
Yes.
We have a new course coming up. So with our oral mucositis, and we have a product that's going to be launching very, very soon. So we're excited. We have a lot of great things in the works, definitely. And Pam, thank you so much for being on board. And thank you, Dr. Rowling, as always. You're amazing.
You all are welcome. And I want to thank everyone then for being here this evening. And with that, we will go ahead and close. If there aren't any other questions, I would encourage you again to bookmark the banner at the top of the screen. Definitely reach out to us if you want to know more about the oral rinses course. We can direct you to that course as well if you haven't taken it. If it's been a little while since you took it, you may want to take it again, because Dr. Moskowitz adds an abundance of citations, and he's always updating that course. So definitely reach out to us for that. And thank you both, Pam and Angelique. This was Pam's inaugural webinar with us this evening, and we know that she worked extremely hard on this. So I really appreciate it. It really showed. And thank you to all of you for being here this evening. And thank you to ioTech for supporting the course.
Thank you so much. I look forward to doing a few more of these in the future for sure.
Thank you. So we're going to go. Thanks, Angelique. We're going to go now and tell you all good night. You'll be redirected to the quiz to complete. You'll also receive a reminder email or two from us as well. Please check out the website for the oral rinses course. There's a course that I present on xylitol on behalf of ioTech. And beginning in March, I'll be presenting a course on oral mucositis on behalf of ioTech as well. So good night, everyone. Thank you for being here.
Night. That was so much fun.